Hello, I am Gary Mintz. My co-moderator is Myeong-Ki Hong, and we're here with Drs. Regar, Dr. Ali, and Dr. Hahn. And this is a wrap-up interview about imaging, but I'm not going to wrap up anything. I want to talk about two trials. I want to talk about IVUS ACS, which obviously was published but is not being presented here, and perhaps with the Renovate ACS sub-study, and then I want to shift to PREVENT. So IVUS ACS was a randomized study in China of 3,500 patients, roughly a little less than half were ACS, 30% were STEMI and 30% were non-STEMI with positive outcomes. And it was part of a 2x2 randomization with a pharmacologic subrandomization as well. So my question is this. Given all the data with ACS, and Ziad, you commented at this morning's session, all the data with ACS, the data with STEMI, the registry data from Korea, why shouldn't primary PCI be imaging guided?
So I think there's one fundamental here that I think is important, and that's the presence of large burdens of thrombus or not. So I think a primary PCI for a STEMI situation is an entirely different animal than a non-STEMI ACS. And the reason is that imaging really guides us by what we can see, and if we're really obscured by thrombus, and then as I mentioned this earlier, by sympathetic drive in the ACS or STEMI patient, then it's hard for us to gain the benefits of intravascular imaging, which really are the determination of vessel size, normal to normal, and then maximizing expansion.
So then how do you explain the fact that the STEMI patients in IVUS ACS did better when imaging guided, and that the CAMER registries are all primary PCI?
Yeah, I have a difficulty to explain that. I mean, when you dive into the IVUS ACS study, there were not very huge differences in the acute procedural outcomes of the imaging-guided group compared to the non-imaging guided group. These were relatively marginal improvements in stent and post-dilation use, which were both above 95%. In the minimal stent diameter, it was like less than 0.1 millimeter difference in the maximum device size used. And so usually we think these are related to device size and a bigger minimal stent area, but I still have difficulty determining how the acute procedural imaging tied to this benefit in the long term. Maybe some of the other panelists have an idea.
So in my opinion, there are two reasons for reluctant or infrequent use of intravascular imaging for patients with a STEMI. One is the patient condition. Sometimes patient is very unstable, or they might have a cardiogenic shock. So in that conditions, intravascular imaging is very difficult to use. And the second thing is many STEMI primary PCI procedures can be done during the night or off work hours. So in that cases, we have to hurry and complete the procedure very quickly. So that's those are two reasons. So in my case, it's substantial portion of the patient with the STEMI have multivascular disease. So I prefer stage the PCI in that cases. So non-confused lesions, I definitely use intravascular imaging, and then we can check the culprit lesion again. So if procedure is incomplete, maybe we can have some additional procedure for culprit vessels.
I mean, I must confess, I'm also influenced by my colleagues in Harbin, and they do, believe it or not, 3-vessel OCT on almost every STEMI patient. The STEMI lesions, if there's a thrombus burden, they do thrombus aspiration, and then they do OCT-guided primary PCI. And of course, they're into this erosion. So if they think it's an erosion, they try to treat it medically. And then they go on to the other vessels, the patients who have multivessel disease. But they do primary PCI in essentially all their STEMI patients.
But you remember, Gary, from the total OCT sub-study, even after aspiration, the amount of thrombus that's actually removed is about 20%.
Or, a better way of saying it, it's almost still there, all still there.
Right. So, I don't see the value of that other than allowing you to provide clearance of the artery to actually get your imaging performed.
And that's why they do it.
You get two things. We did these sort of trials in the past. So you get two things. First, you get initial flow on the artery by removing a little bit of thrombus. And the second, by doing OCT, by flushing, you again install a sort of flow, and you give the vessel time for flow-mediated vasodilation. So at that point, you are in a better position of selecting your stent appropriately sized, because it's the factor restoration of some flow plus flow-dilated vasodilation. So you have both effects, and that helps. And you can, of course, with the imaging, you have a better idea how long to select the stent and to make sure that you cover the rupture site. We know that angiography is often misleading. People tend to place the stent at the site of maximum thrombus, but that is not necessarily the site of the rupture.
I'm going to keep playing devil's advocate here, Gary. We purposefully decided to exclude STEMI patients from Illumian 4. The reason was, when we looked at the STEMI population from all of the randomized controlled trial data that we had, including Horizons AMI at CRF, which was 13,000 patients, the event rates at 2 years were 2.4%. If you survived the STEMI, you did extremely well. Why? You got a huge stent. Most patients presenting with STEMI present with a proximal vessel lesion. They then get a large stent placed in the proximal vessel, and their subsequent outcome, as we all know now, is actually better than the patients who have end-STEMI ACS because of their huge plaque burdens. So I'm still struggling to understand how the primary PCI, where you don't really have the problems that you have with diffuse disease at either end, poor landing zones, how exactly it led mechanistically to this huge benefit.
Yeah, but to look at the other side of the argument, the outcomes were better. And it's true of, you can say you can't understand the mechanism, but we don't always understand the mechanism, but the outcomes are better across the board. Okay, so now let's move on to PREVENT. As everybody knows, PREVENT was a randomized trial of preventative PCI versus guideline-directed medical therapy in vulnerable plaques, starting in the eras of virtual histology and BVS, and recently published in Lancet and presented at the ACC. So, Evelyn, or Myeong-Ki, please, how do you integrate PREVENT into what we are doing today, both in terms of imaging guidance, vulnerable plaque detection, and so on?
First of all, before the publication of the PREVENT, we always this is a vulnerable plaque, but the FFR is more than the 8508, and the delay and the defer. That is the common concept. But this paper was a first demonstration of preventive PCI is another alternative the treatment strategy. We also I think that is the originality of this paper. And second one is the very severe disease. Even in the FFR is the more than 0.8. That time, why not? We try to the imaging. This is a real vulnerable plaque or not. that is after the reading of the prevent, I have to change my practice pattern.
And how would you change it?
No. What I mean is not totally. I do not totally agree with the
Okay.
a little bit the shift.
Well, I think the practical shift is now if I'm performing a PCI on a culprit lesion in an LAD, and I have a proximal vessel lesion that exhibits the features consistent with a vulnerable plaque, I'll either extend the length of my stent, I may place an additional stent, and if it's in the non-culprit vessel and I don't have to change guides, I think I'd be much more prone to image it to determine whether those lesion presence are there. There's a few things about that study that we should focus on. There was a really interesting slide this morning by Shamir Mehta where he showed that actually in the complete study, the patients that did worse actually had tighter lesions. And if you go back to prevent, these were not that moderate. The QCA were in the high 50s, so these are 60 or 70% lesions. The minimal lumen areas are in
the median QCA was 55.
median QCA is 55, so and the range goes up into the 70s.
Yeah.
But importantly, if you look at the minimal lumen area, they're in the low 2s, 2.1 to 2.2. These are pretty tight, right? But I mean, these were things that if we look at all of the IVUS data, you could say are somewhere in the 80% range for positive FFR. So they're not so simple. The take-home message for me from Prevent was, if you perform PCI on these lesions, it's very, very safe. I mean, you're talking about an extraordinarily low number of events at 2 years in the prophylactic PCI group.
But I'd like to point out that these were all FFR negative. And the combined study, granted just a registry, were all FFR negative lesions. So should we even be using FFR?
No.
Okay.
Right? Pectosobs combine, and now you have Prevent. So the previous data showed, and Niels Johnson is big on this, that if you have a negative FFR, your chance of a spontaneous myocardial infarction is less than 1% per year. But now the whole purpose of that was the FFR can't see inside the artery. So you're screening an entire landscape like a whole farm. But what we've done by imaging is highlighted the area that's actually the at-risk part of the farm, right? So they have the features that actually lead to events.
So,
Please.
yeah, I have some difficulty to combine the results of Prevent with those of the Flavor trial. So in the Flavor trial, IVUS deferred lesion shows very similar results with the FFR deferred lesions, but in the Prevent trial, the imaging wins FFR. So I'm a little bit have the difficulties of combine the two results. And practically, I would like to agree with Dr. Hong. So in multivessel disease, after the treating culprit lesions, probably I can fix the non-culprit lesion or non-culprit vessel because I already used balloon intravascular imaging. But in single lesions, I do not treat the lesions. I adhere to the medical treatment.
You know, I would point out that Prevent had, if you will, two errors. They had the BVS error and the science error. And if you look at the medical therapy arms of those two errors, they were fundamentally different. So at the BVS error, which was the earlier part of the study, the event rate at 4 years after with the Apple Medical Therapy group was close to 8%, while in the Zions era, the event rate was reduced by 50%. So my biggest problem with Prevent is there were so many moving parts during the study that it's hard to make a definitive statement, we should be doing this based upon Prevent. I think your concept of extending a stent where there's a more proximal, more distal vulnerable looking lesion. I think we could have made that case based upon the registries all along. But I don't think this gives the average interventional cardiologist license to treat what he thinks is a vulnerable plaque, especially since we haven't tested his ability on the fly in the cath lab to decide whether a lesion is or is not vulnerable.
Well, then let me push back a little bit, Gary, and say, then why can we do it with FFR?
Do which one with it?
So FFR dictates a vulnerable plaque by a low FFR value,
Right.
right? But really what FFR was doing was preventing a periprocedural MI. That's a totally different era. The periprocedural MI definition in FAME1 was a CKMB less of 3 to 5 times. That's a tiny amount of injury that you can get it. So all of this data tracks upon that. So what would happen if we were using FFR positive for intermediate lesions at this stage? You'd probably end up in the same situation if you had optimal medical therapy.
I mean, I have critically looked at the FAME1, FAME2, and I think that there's a little bit of hype and exuberance based upon what is actually a modest amount of data.
I couldn't agree more. I mean, what I think is missing in our field is a assessment of intravascular imaging versus physiology versus optimal medical therapy in intermediate lesions. And if I was to bet, they'd be exactly the same.
Yeah.
Because you need enough time to accrue events. Look what happened in ischemia, in prospect, in LRP. You guys all showed it very elegantly. The events don't happen until like 3 or 4 years. And then when we look at prevent, you capped these lesions, and then at 3 or 4 years, they started happening again.
Or something is happening.
Right, you can't stop it because
Right.
you can't stop the disease
Right.
other than with medical therapy.
You know, and the last point I want to make or ask, you know, in prevent, almost nobody got PCSK9s. And high intensity statins, only about 60%. So what should be optimal medical therapy today, and what should be the targets? So I don't take care of patients, so
For me,
yeah.
I think statins are a had-been drug. I think patients should be on PCSK9 or inclisiran. I take a PCSK9. My LDL was 150, now it's 80. And I think we should drive our LDLs down to less than 50.
However, okay, Evelyn, European perspective?
I think optimal medical therapy is the hardest thing to do for an interventional cardiologist. Let's be honest. I mean, we are interested in treating lesions. We are not so interested in reading charts of blood pressure or reading charts of LDL. I wouldn't dismiss the statins so much. I mean, remember, we have studies showing that under intensive statin therapy, thin cap atheroma can change to thick cap atheroma. So there is this pleomorphic statin effect that is not fully understood. I would not dismiss the statins completely, but
But if I
it's
can
true.
interrupt, but that's dependent upon the statins having an optimal effect
And being taken.
and be taken, right? So
That's
Sure.
the benefit of the injections. You remove adherence completely.
you know, I show this slide from Steve Nichols that shows the relationship of growth in fibrous cap thickness to reduction in LDL, and these were all, or mostly statin trials. I don't know if they were all statin trials, but these were driving the LDL way down. And we know that there's some patients, you put them on statins, and their LDL goes down to your 50, and there are other patients that it doesn't budge very much. Okay, so I think our time is up. I hope that people watching this video learned something about the two trials that we decided to discuss. And I want to thank my panelists and co-moderator for joining us in this interview. Thank you.
Thank you.
Thank you.